Eventually, in respiratory system, we come to the discussion of pneumonias in children. Pneumonias in children are evergreen topic. You always get questions from this in NEET PG. You get cases of these, and guidelines are asked even as fact-based questions. Sometimes they are asked. So pneumonias in children, first of all, the first thing that you need to know that they are the most common cause of death worldwide, globally, in children less than 5 years of age. This thing can be asked as an MCQ. They can cause what is the most common cause of under 5 mortality rate worldwide. So the most common cause of under 5 mortality rate worldwide is pneumonias. Pneumonia, technically speaking, is a infection and inflammation of the alveoli. But that is a very simplistic definition. Pneumonia in children tends to produce a very particular picture, and in fact, respiratory symptoms with or without fever. Many times fever may be mild or fever may not be that conspicuous, but respiratory symptoms are very prominent, and so the diagnosis of pneumonia is mainly made clinically. Before we go towards the diagnosis, first we need to understand the etiological agents. So what are the agents who cause pneumonia? They vary according to the age group. If the age of the child is less than 2 months, the causes for pneumonia are same as for neonatal sepsis, the ones we discussed in neonatal sepsis module. So in case of world, you will have group B streptococcus. In case of India, you will have Klebsiella. So this is something you have already done, right? If the age of the child is between 2 months to 5 years, pneumonias are mostly caused by viral infections, followed by bacterial causes. Among viral infections, the most common viral cause is respiratory syncytial virus. So RSV is the most common cause. Among bacterial causes, the most common pathogen is Streptococcus pneumoniae, also called as pneumococcus. The third age group is 5 to 15 years. In 5 to 15-year age group, pneumonias in children are mostly caused by mycoplasma. So mycoplasma is the most common cause in 5 to 15-year age group, followed by pneumococcus, that is Streptococcus pneumoniae, followed by a member of Chlamydia family called as Chlamydophila. So these are the etiological agents across various causes. As an extra edge thing, you can remember that children who develop cystic fibrosis and they develop pneumonia, we have discussed in cystic fibrosis module in detail, but no harm in revising at one place. The overall most common cause of pneumonia is Pseudomonas aeruginosa. Adult also it is Pseudomonas, but in case of children, you have Staph aureus followed by Pseudomonas, right? Another question, potential one-liner. If question asks you what is the most common cause of necrotizing pneumonia, where necrosis of the lung parenchyma sometimes extending to the bronchial elements, that is seen. Necrotizing pneumonia is mostly produced by Staph aureus. Now this is a potential MCQ. It is prominently mentioned in some of the textbooks. So with this background in mind regarding etiology, let us move towards the diagnosis of pneumonia. How we make the diagnosis. I am skipping the clinical features only because diagnosis is based upon clinical features. So diagnosis is made clinically. In India as well as most parts of the world, diagnosis in pneumonia is made clinically. For that, we follow the criteria given by WHO. So there is a WHO IMCI, Integrated Management of Childhood Illness guidelines. These guidelines were updated in 2015 and their periodic updates, small updates keep on happening. These WHO IMCI guidelines are for two specific age groups. For newborns up to 2 months of age, you have a different set of guidelines. Those guidelines I have already discussed in the chapter of neonatal sepsis. So for less than 2 months, you can refer to the chapter, the module on neonatal sepsis. For 2 months to 5 years of age, maximum questions are asked from this, and these we will be discussing here. So how do you classify pneumonia in these children? Here, pneumonia is diagnosed clinically. So, what is the criteria? It says that first of all, there should be some fever or any respiratory feature in the child. So, any child aged 2 months to 5 years having either fever or cough or respiratory distress, right? Either a febrile illness or a respiratory feature. If is found to have either tachypnea, what is tachypnea? Rapid breathing, or chest indrawing, either of the two, the child is labeled as pneumonia. So, fever is not mandatory, cough is not mandatory, either of them, some respiratory feature should be present. If the child is found to have either tachypnea, age inappropriate breathing, or chest indrawing of the chest muscles, retractions, then the child is said to have pneumonia. It has a very strong predictive value. In a child with febrile child or respiratory illness child, presence of tachypnea or chest indrawing is assumed to be pneumonia unless proven otherwise. And second category, if the child aged 2 months to 5 years having fever or cough or respiratory distress has any danger sign, we call it as severe pneumonia. Remember that severe pneumonia is also called as very severe disease. There is no such thing as very severe pneumonia. Severe pneumonia and very severe disease. We have only two categories. So, what are this is how you make the diagnosis of pneumonia. So, what are the things that you should remember from entrance point of view? First of all, how do you define tachypnea? So, definition of tachypnea is important. It has been asked as a standalone question in NEET PG also. If the age of the child is less than 2 months, tachypnea is defined as respiratory rate of equal to or more than 60 per minute. 2 to 12 months, it is equal to or more than 50 per minute. And 1 to 5 years, tachypnea is defined as respiratory rate equal to or more than 40 per minute. This is how you define tachypnea in the child. After talking about tachypnea, we talked about danger signs. So, what are the danger signs? So, danger signs according to IMCI protocol. There are 6 danger signs that you need to remember. The first danger sign is lethargy. Lethargy is defined as abnormally sleepy or difficult to awake. Abnormally sleepy or difficult to awake. Second, any child having stridor at rest, also written as stridor in a calm child. Presence of stridor indicates upper airway obstruction. If pneumonia should not have stridor, if there is stridor present, it indicates a coexisting pathology, probably some infection happening here or some obstruction happening here. This is known to be a danger sign because it can cause worsening of the symptoms and can compromise air exchange, the gas exchange occurring in the pneumonia, worsening the outcome. And so, stridor at rest is considered to be a danger sign. Third is severe malnutrition. So, severe PEM, in short I am writing protein energy malnutrition. Fourth, if the child is having convulsions. Fifth, if the child is having inability to feed or drink. There is a possibility the child will develop either hypoglycemia or dehydration. So, that will complicate the diagnosis. You cannot manage at home. So, all these children with danger sign, they need to be managed at hospital. That is why we are defining pneumonia and severe pneumonia separately. And sixth feature is persistent vomiting. Any patient with vomiting more than 3 vomitings in 1 hour is called as persistent vomiting. So, these are the 6 danger signs. So, respiratory feature, febrile child, any one danger sign, even if tachypnea or chest indrawing is not present, you will call it as severe pneumonia in the patient. So, this is how you make the diagnosis of pneumonias. Now, coming to investigations. Investigations are not mandatory. They are not mandatory in pneumonia. However, in case of severe pneumonia, they can be performed. Can be does not mean ki karna hi hai, because the diagnosis is based upon based upon clinical findings. Severe pneumonia, they can be performed to rule out occurrence of any complications. Right? So they are not mandatory. What are the things that can be done? You can perform a complete hemogram, and you can perform inflammatory markers like ESR and CRP. And thirdly, you can perform a chest X-ray. As I keep saying, they are not mandatory, they can be done. So complete hemogram, ESR, CRP and chest X-ray are the usual investigations which are performed. Normally it is seen that when you do chest X-ray, two types of patterns can be seen. Generally, there are 100 different kinds of patterns, but at your level, at MBBS level or pre-PG level, you need to understand that broadly two types of patterns can be seen. You can have a pattern in which there is lobar consolidation. Lobar consolidation. These are the children which will have a consolidation occurring in the chest X-ray in a specific area or specific lobe more than the others. Lobar consolidation will typically be produced by Streptococcus pneumoniae or pneumococcus. These pneumonias where there is lobar consolidation are also called as typical pneumonias. These children will have fever, productive cough. Sometimes young children you cannot make out productive cough, but traditionally speaking, fever, productive cough, and they will have a localized lobar consolidation. Sometimes bronchoconsolidation can also be seen. So these are the typical pneumonia. So remember, lobar consolidation, feature of Streptococcus pneumoniae. Second is your interstitial infiltrates. So there will be diffuse, bilaterally symmetrical interstitial infiltrates more predominant in your perihilar areas. So bilaterally they will be present. So these interstitial infiltrates, whenever you are thinking of interstitial infiltrates, think of atypical organisms like Mycoplasma or Chlamydia as the likely possibilities. They will tend to produce a atypical pneumonia which will have low-grade fever, dry cough, and there will be no lobar or bronchopneumonia. So these are the two types of patterns which can be seen in chest X-ray. So if I have to show you a picture, let us have a look at the picture. Look at these two photographs. Here in this picture, on this picture, you can find that there is lobar consolidation in the right upper lobe. So this looks like a typical pneumonia produced by Streptococcus pneumoniae. On the other hand, if you look at this picture, you will find that there are diffuse interstitial infiltrates which are present, and they are predominantly present in the hilar area. So they are extending out from the hilar area, they are present bilaterally. So this haziness interstitially is seen in patients with atypical pneumonias. Now moving over to talking about the complications in pneumonia. Most common complication in pneumonia is parapneumonic effusion. Parapneumonic effusion means fluid collects in the pleural space adjacent to the pneumonic patch. That is considered to be the most common complication. This pleural effusion need not be mobilized, nothing needs to be done. You give antibiotic for underlying cause, this automatically gets reabsorbed. It is a reactive fluid formation. Second is empyema. Empyema refers to pus in the pleural cavity. In young children below 2 years of age, empyema is mostly caused by Staph aureus. This is your MCQ point. Above 2 years, it is usually Streptococcus pneumoniae, but can be Streptococcus pyogenes, Staph aureus, and many times mixed culture is obtained. So that is why only less than 2 years is the one which is asked in exams. Third thing is pneumatocele formation. Pneumatocele is an important thing on which already in AIIMS entrance exam, visual question has been asked. Pneumatocele. What is pneumatocele? Pneumatocele refers to, pneumato means air, cele means cyst or cavity. Air-filled cystic cavity forms in the lung parenchyma. Pneumatoceles are typically produced with infection caused by Staph aureus. It can also be seen with infection caused by Klebsiella. Sometimes non-infectious states like kerosene poisoning can also produce such a picture. So Staph aureus is considered to be the most common cause of pneumatoceles. This is how a pneumatocele will look like. If you see here in this upper lobe, right upper lobe, you can find there is a well-defined air-filled cystic cavity which is present. This is how pneumatocele looks like. So you get a photograph like this, child with pneumonia found to have the following complication as shown in the chest X-ray. What is the likely diagnosis? Pneumatocele, most likely Staph aureus, not an option. Klebsiella, not an option. Kerosene poisoning can also sometimes produce it. Other complications include pneumothorax. There can be ARDS, acute respiratory distress syndrome. There can be septic shock. And there can be MODS, multiple organ dysfunction syndrome. Lastly, there can be pulmonary hemorrhage. So these are the various complications associated with childhood pneumonias. Now coming to the treatment of childhood pneumonias, treatment is very straightforward. If there is no tachypnea, no chest indrawing, and no danger sign, none of them is present, there is no pneumonia. It is simply called as upper respiratory infection, cough and cold. No antibiotics are needed. No antibiotics are needed. For fever, you can give oral paracetamol or acetaminophen in a dose of 10 to 15 milligram per kg body weight per day. Dose of PCM can be asked. These are COVID times. And children may, what is the dose of paracetamol you give? Not only for in COVID related fever, any fever. The dose is always 10 to 15 mg per kg per day. This is the first thing you learn when you enter into MD pediatrics. For those who are not willing to be a pediatrician, still entrance exam you have to pass, and for that remembering one dose is not going to make much of a difference. Remember this dose. So fever, oral PCM. In case the child is having pneumonia, as we described above, you will use oral antibiotics. There is no need to hospitalize. Oral antibiotics are the drug of choice. What is the drug of choice here? Oral amoxicillin. Oral amoxicillin is given in a dose of 80 milligram per kg body weight per day in 2 divided doses. So 40 milligram per kg daily morning, 40 milligram per kg evening, given for 3 to 5 days. In case of India, India belongs to a high risk zone and for pneumonias, and we give for 5 days. If they ask range, it will be 3 to 5 days, and in India we give for 5 days only. So Western countries 3 to 4 days bhi de dete hain. India we have to give for 5 days. Any patient started on oral amoxicillin needs a review in 48 hours. In case the patient is improving, you will continue the therapy and finish the course. In case the patient is worsening, you will refer to the higher center. So review in 48 hours is important because you are not admitting these patients. In patients of severe pneumonia, IV antibiotics will be needed. IV antibiotics will be needed. So ampicillin with gentamicin will be the therapy of choice, and you will give for 5 days. Doses are not important. In case, now there is a catch here, in case you are sitting in a primary healthcare center, we are talking about PSM related questions, you are sitting in a PHC and a case of severe pneumonia is diagnosed, right? What you will do? Here you need to refer, but you will not refer directly, you will give first dose of antibiotic and then refer to higher center. Now people often ask me, there is a lot of dilemma here. कौन सा antibiotic देना है? See, guidelines are very clear in this. Some of the PHCs, there may be facility available or the expertise available for giving intravenous or intramuscular injection. So there you can use parenteral antibiotic also like ampicillin. But if that scenario is not there, like it happens in most of the PHCs, where sometimes even the medical officer is not there. So there you give the first dose of oral antibiotic. So the choice of antibiotic before referral depends upon the local, whatever is the best availability. So important is one dose of antibiotic should be given, and then the child should be referred to higher center. If you are sitting in a higher center, you will admit the child with severe pneumonia and start with IV antibiotics along with supportive therapy. Supportive therapy will include steam inhalation, fever control. If there is hypoxia, SpO2 less than 92%, you will start room air, you will start oxygen, etc., etc., etc. So those things will not be asked in your exam. So this is the overall management that you need to remember. There is also a color coding which is used in IMCI protocol. Just remember that children with no pneumonia are labeled as green color, children with pneumonia are labeled as yellow color, and children with severe pneumonia are labeled with red color. So this is the color coding that is sometimes followed. So this finishes the discussion of pneumonias in case of children. Let us have a look at one MCQ example. Very similar question was asked in a recent entrance exam. So the question looks something like this. Look at this question. 2-year-old child with weight 11 kilograms has moderate grade fever, cough, chest in drawing, and respiratory rate of 38 per minute. What is the optimal management according to IMCI? First, you need to see pneumonia is there or not. There is fever and there is respiratory symptoms like cough. Right? So any child between 2 months to 5 years, if there is fever or a respiratory symptom, if there is chest indrawing or tachypnea, you call it as pneumonia. There is no tachypnea here because 1 to 5 years the respiratory rate should be more than 40, but chest indrawing is present. So chest indrawing is present, so the child is having pneumonia. Is there any danger sign in this child? There is no danger sign. 11 kg in a 2-year-old child is a fairly normal weight, right? So what is the optimal management according to IMCI? Any child diagnosed with pneumonia, you have to start oral antibiotics and review in 48 hours. So your answer will be B. This is how questions are asked. If you have understood the guidelines, implement them in the case, very easy. If you're not thorough with the guidelines, you bungle up with them, you will not get your answer correct, right? Lastly, let us discuss some one-liners, miscellaneous one-liners, which can be asked in exam. The first one-liner is, any child having a recurrent pneumonia with malabsorption. What will you think of? You will think of cystic fibrosis, right? Another child, any child or even adult having recurrent pneumonia in the same lung or same lobe. It can come as a case. A 2-year-old girl developed pneumonia. It was severe pneumonia. Chest X-ray was done. It showed consolidation in the right upper lobe. She was given antibiotics. She got fine. 2 months later, she again developed pneumonia involving the same region, same consolidation. What other investigation you will do? So whenever there is recurrent pneumonia in the same lung or same lobe, you have to rule out, is there mucus there draining properly? In other words, you will like to look for any bronchial obstruction of that particular segment. And so the investigation you will perform in these is bronchoscopy. So you will do bronchoscopy as the investigation. Bronchoscopy will be done to rule out any bronchial obstruction pathology. It can be a endobronchial tuberculosis, it can be just simply, bronchial koi aplasias, bronchial dysmorphisms, hematomas, it can be extrinsic lymph nodes compressing upon the bronchus, it can be a fungal ball, anything can be there. It can be neglected foreign body in young children. So these, all these, and adults, again, TB and all these things, localized obstruction can be produced. So bronchoscopy needs to be performed in all of these patients. And finally, patients who have kerosene poisoning, they have a high risk of developing necrotizing pneumonia. They have a high risk of developing necrotizing pneumonia. Kerosene poisoning, also called as hydrocarbon or aliphatic hydrocarbon poisoning, is even if the child has not, aspirated, even if the child has ingested, it is a volatile toxin. Kerosene is considered to be a volatile toxin. and the fumes or the vapors can be inhaled if the child has, taken it in the gut, and that can produce pneumonia in the child. But conservative management is needed in most of these patients. And to avoid any formation of vapors or chances of aspiration, whenever kerosene poisoning patient presents to you, you should not do any gastric lavage or you should not induce any vomiting in the patient. So this is something you must have read in your forensic medicine part. So this finishes the discussion of pneumonias in children. Small topic, extremely important for your exams.